Okay, are we ready? Everybody? Chewing on our popcorn and having our snack bar? Taking our drink out of our ice water? Let's get going. Hi everyone, welcome to the Affinia Healthcare Leadership Academy, Session 3. I welcome you to today's session. And to those of you who are joining by teleconference, welcome to all of you. We're glad you're here. Today's session is titled Health in Society. Health in Society. This is the third of 19 sessions, just to remind us, the third of 19. Today's session, we will define and explore the determinants of health, just generally speaking, the determinants of health. We will review, talk about the cornerstones in healthcare delivery, as I call them, the cornerstones, and look at some policy statements on how we distribute healthcare in the United States. So generally, this is what we will cover over the next 45 minutes to an hour. First, an overview of the Academy schedule, just to remind us. Our first two sessions were specifically about the community health center environment. I gave you an introduction, the history of community health centers, and we looked at the Health Resources and Services Administration and the federal bureaucracy from which our federal grants flow and how those regulations, laws and regulations work. So those were the first two sessions. Today and the sessions that follow will be more generalized. In other words, less specific to the community health center environment, more specific to healthcare overall. So we begin with a quick look today at health. Later we will review, later in our series, we will review the delivery of healthcare in the United States, policy, social determinants, the external and internal environment, what mission and governance mean in healthcare, vision and values, the human resources function, the finance function, quality improvement, IT, things of that nature. So all of you have access now and probably have been sufficiently informed about what these 19 sessions in this series look like. You'll find all of these represented in your slide decks that accompany the presentations. Again, as always, stop me as we go along if you have a comment or a question. If you'd like to explore a topic more specifically, we have up to 90 minutes. 90 minutes is the drop. If we get to 90 minutes, we'll kind of stop because that's the length, the outside length of our sessions. Okay, ready to go? Good. So each of us has a definition of health. We may not have sat down to write it out, to think about it. Health means different things to different people. Health can mean different things to each of us at different parts of our lives. To some of us, health is a science. To others of us, health is something less than or different from a science. And again, at different parts in our lives, depending on the status of our health may, or the status of a loved one or friend's health, we may have a different concept or idea of what health means. In the literature, let's look at three different ways in which health is defined and depicted. The first, the medical model. So as physicians and other licensed caregivers are trained, there's a certain model. This particularly comes out of allopathic medicine, where MDs learn their skills and their trade. That is allopathic medicine. The medical model is defined rather simply. Emphasizes the absence of illness or disease. So whatever it takes, whether it's a treatment plan or a prescription or a set of recommendations that come from the physician's office, it's the absence of illness or disease, whatever can cause that to occur. This definition came about in the mid-1800s, by the way, and so it's been around for quite a long time. The absence of illness or disease. In later years, as the World Health Organization surfaced and began to influence health thinking and policy across the world, and as we started to look more at public health, as the emphasis of public health, so for example in the United States, public health has its genesis right after the 1900s, beginning of the 1900s, we started to look at health in a different way. Health meaning geared toward health promotion, prevention, and protection for public benefit. So in addition to thinking about health as the absence of illness or disease, we have a wellness model of health, where we emphasize health promotion, prevention, and protection for the public's benefit. So that's a second way in which our society looks at health. The literature defines health, and studies about health care and health services are derived. A third comes about by adding one particular component, and that is our spiritual side. So there's a holistic look at health that's gained in prominence more so, say, in the last 30, 35 years. The holistic model of health suggests that we emphasize a complete state of physical, mental, social, and spiritual well-being, leading to wholeness. So generally speaking, in healthcare organizations like community health centers, critical access hospitals, public health sponsored by government, we're going to be looking at these various facets: the physical, the mental, the social, and we've learned also to add the spiritual. Well, whatever our spiritual concept is, we've learned to add that, as in various cultures, the spiritual meaning of health and what leads to spiritual wholeness is very, very important. So 3 definitions of health in the literature: medical model, wellness model, and a holistic model of health. Again, I want to re-emphasize, health to each of us means something different. And health will mean different things for us at different parts in our times in our life that depend on health status of ourselves and our family members and friends. There isn't one of us here who can't point to a time in life when your questions about health weren't challenged, or your convention about health wasn't challenged based upon how your health was impacted or the health of a loved one or a friend. I think we could all agree upon that, right? Determinants of health. What is it that causes health to occur? What is it that informs our health status? What determines health? Going back to about 1979, there's a researcher whose name is Bloom, B-L-U-M. I think the first letters were D-L, Bloom. I believe that's right. D-L, came up with these determinants and spent his career, Dr. Bloom spent his career looking at these determinants. What is it that determines health status? They've been identified, the determinants, in 4 categories. Let's have a look at those. 4 categories of determinants: lifestyle and behaviors, our heredity, the environment that we live within and that affects us, and medical care. Let's define and explore these more closely. So lifestyle and behaviors, especially this category, we can control. We have every opportunity, individuals have every opportunity to control our lifestyle and our behavior. So sometimes things that affect our health status, whether that's to improve it or cause it to be indifferent or affect it negatively, is about our lifestyle and our behavior. And I we could talk about this. We have a room full of nurses today, so we could talk about the different ways in which patients have lifestyles and behaviors that may or may not be recommended if their health status is going to be at a certain level, right? So that's one determinant, our lifestyle and our behavior. Another is heredity. Heredity's our family, where we came from, that creates us physically. If you will, for the lack of a better way to describe it, it's our DNA. From where did we come? Until only recently, we thought that we couldn't affect heredity. What it is what it is. We've all said that, haven't we? It is what it is, right? Not so. Today's science is leading us to conclusions now that there will be ways in the future that we can put things into our body to affect potential outcomes related to what's known about our heredity. This is here, this is coming. So those conventions we have about heredity are changing. Typically, historically, we have been unable to change or affect heredity. Our parents are our parents. Our sisters and brothers and grandparents are those people, right? So we can control lifestyle and behaviors, we can't control heredity, or at least we thought we couldn't. Number 3, the environment. We can look at this in so many different ways. Environment can be considered our physical environment. So we live in the St. Louis region. That's can be defined as a physical environment. A physical environment may be your home, the street on which you live, the ward in which you live, the zip code where you reside. Environment can also be average temperature through the year. How many seasons are there? What's the topography of your geography? What around the physical environment can and does affect our health? You might think about it this way. Someone who lives in the Caribbean likely lives different ways than someone who lives in Juneau, Alaska. Would you agree with that? Okay. Someone who lives in the mountains of Colorado might have a different lifestyle than someone who lives in the plains of Nebraska. Different ways in which the physical environment we live in affects us, and we in turn affect it. Other aspects of the environment relate to the social and the psychological. The environment within which we live, our groups, our primary groups and our secondary groups. In what ways do those impact health? How might those be a determinant of health for us, for our patients, for people in a community? All of these relate to the determinant we call environment. There are a number of ways to define it and study it and present it. So we can fix much of our environment. It's hard to fix environment. If you've lived in a certain region all of your life and you plan to live there with your loved ones all of your life, it's not the easiest thing to do to say, I'm just not going to do that anymore. We've known people who have. You may be among them. But that's not always easy to do. It's not always easy to change or address in some way our environment as it relates to the people we relate to. But sometimes people do that, and it could be to help improve their health. So that determinant, or this determinant environment, is one that we can control. It may be harder to control than lifestyle and behaviors. So I'll give you a good example. I'll use myself as an example. When I was a youngster in my late teens and early 20s, I liked fast cars, and I liked to drive them faster than I should have. Right? Can we all point to an example or examples of things that we can change in our lifestyle and our behavior The same with the environment, just requires different types of change, different lifts. Pretty hard to change our heredity, or at least we thought so. Now on to medical care. This is an interesting one. If you've gone ahead and read what's here at the bottom of your slide, you've taken the thunder out of my presentation, so I'll try to get there more quickly. Medical care means the provision of care, whether it's accessible and in what type. So medical care can mean your exchange with doctors and nurses and dentists and psychologists and pharmacists. It can mean where is a hospital, emergency department in proximity to where you live. There are different ways in which we identify and define medical care. I'll give you another example. Here in St. Louis, we're 5 minutes from very robust, world-class health services delivery. If you live in Alaska, I mentioned Alaska earlier, you can live in places where it's 150 miles to the nearest primary care provider. So medical care means different things for people who reside in the United States of America. So it varies depending on where you are. It will vary. In the United States, we spend about 90% of the total expenditure, the national expenditure, on the medical care determinant. We spend about 90% of our total expenditure on the medical care component, determinant. Yet, it's been researched and generally held that that doesn't mean that we're making absolutely the best decisions. We spend 90% of the total expenditure on medical care, yet among the determinants, medical care has the least impact. The least impact on population health status. Stated another way, lifestyle and behaviors and our heredity and the environment that have a greater effect. They're about 40, 30, 20, 10, by the way. Depending on which researcher you look at, 40, 30, 20, 10, which one would be the highest, do you think? Who would like to take a guess? Which one?
Lifestyle.
Lifestyle, right? Okay, lifestyle behavior. Do others of you agree? Some researchers might suggest that's 40, and others have said it's 30%. If you were to argue in a point, which would be another that could be 40% and not 30? Environment, right. We can't control heredity, we can control the others. So our environment, whether that's 40% and lifestyle is 30 or vice versa, those are the two higher components. Yet, in the United States, we invest about 90% of our total resource in the medical care component. This might be a reason why, rather than having a system of care that's about prevention and primary care, we have a system of care that's about sickness, fixing it after it's broken, as some have put it. This is typified in the United States way, U.S. way of looking at the delivery of health care, and has been since this capitalist nation was formed. If you really look at the history, as I have over time, you'll see that it's our thinking, our collective thinking, that lead us to these conclusions. So these are the 4 determinants of health, D.L. Bloom's work, 1979. This still resonates. It's taught in every master's program everywhere. The determinants, okay? Any questions about that? Thoughts, reflections? Cornerstones. I mentioned earlier that there are 3. This is, I've read this in certain writings, the cornerstones of healthcare delivery. I often speak of these as being cost, quality, and access. Cost, quality, and access. You can essentially put everything in a study of healthcare under those 3 headlines: cost, quality, and access. The primary objectives of an effective healthcare delivery system, and I could point to a number of textbooks where This is verbatim in the text, and we learn about these things as being the primary objectives. This does not necessarily relate only to the United States. Anywhere in the world, we could say, for human beings to have an effective healthcare delivery system, what would it look like? So here we go. To enable all citizens to have access to healthcare services whenever needed, and to deliver cost-effective services that meet certain pre-established standards of quality. So there we have cost, quality, and access. If this were a graduate class, I can promise you this would be on the exam. So cost, quality, and access is fundamental to how human beings should think about the delivery of healthcare. So let's kind of look at these more closely. Let's look at cost. Cost has three broad meanings. Means different things to different people depending on what side of the equation we are on. As a consumer, as a provider, as a regulator, as a legislator, as a taxpayer, cost has essentially three different meanings. The cost of production or providing a service. So Affinia Healthcare has certain costs associated with the delivery of care. Hospitals, the government, a primary care practice that's in a town of 5,000, a home health services agency, a long-term care facility or group of facilities have costs to produce. And they can be divided in a number of categories. In fact, they are, starting with salary and benefits, and then we look at supplies and so many other categories. So the cost for providing the service is one way of defining cost. Another is the purchase price. So it's costed by an organization or a provider or a deliverer. For you then, or for me, we buy it. Is it bought through an insurance company? Is it bought through the government as our representative? Or do we have an out-of-pocket expenditure? So the price for the service is another way of looking at cost. Finally, would be the national or global expenditure. So in the United States, if we were to tally the amount of cost associated with the delivery of services for the year 2019, that would be categorized as a national expenditure. We could look at St. Louis in that way. You could look at a zip code in that way. You could look at the state of Missouri, and we do, in that way. So it's the national or global expenditure. So why is that important? For so many reasons. In the United States, our total expenditures on all goods and services, of that total, healthcare is about 17.6% of all that we spend. So it's a major aspect of the cost of being a country, the cost of being a citizenry and residents within a country. There are two definitions here that I do not have represented in your slide deck, but there's rationing, that's implicit, rationing, that's explicit. Rationing, that's implicit, rationing, that's explicit. Starting with explicit. Explicit means there's a budget. You have only so much money you can spend. And once that's spent, theoretically, it's gone. So you manage through that budget based upon the amount that you have. Here's another tidbit. There are 19 industrialized countries in the world. 18 of them have an explicit ration of healthcare delivery services. One does not. The one that is implicit is the United States of America. So 18 of the 19 countries have some universal benefit for all people who live there, except for the United States, which does not. Now, the United States has addressed certain aspects of healthcare through Medicare and Medicaid, and I could go through some of the other ways in which the United States assures that certain groups in our population have access to care. We have to qualify for it based upon our age or our income or other factors. But there are more countries than not that have an explicit budget, and it's a globalized budget. Canada is a great example. Great Britain is another wonderful example. We could go into the international look of healthcare. Probably won't in this series, but it's rather interesting to see how it occurs in India, Japan, France, Brazil. Great Britain and Canada, again, are the two more significant examples, and probably Germany. Ways in which the federal government has designed processes for everyone to have access to a basic set of services. In other words, universal access to care. Of the 19 industrialized countries, the United States is the only one that doesn't have it. Implicit rationing means it's left to the market. Explicit has government control. Implicit means there are factors within a marketplace that dictate whether or not health care is available to a group of people. And oftentimes that relates to insurability and the ability to pay and other factors. So, of course, in the United States, we have people who are insured and people who aren't. That's the primary way in which we separate people and their insurability in the United States. And that's not the way it happens in other industrialized countries. The United States is very unique in that regard. Very unique. We'll come back to that. Hold on to that thought. We'll come back to that. Quality is a second of three cornerstones. The Institute of Medicine, or IOM, that gained its prominence in the late 1990s through a report entitled "To Err is Human," when it was determined that 98,000 people in 1997 had died in hospitals and they should have gone home. And when that report was issued and members of Congress started looking at it, we started thinking differently about what we should be doing to improve quality in the United States. I'm really, that's elementary in my thought process there, but the IOM, the Institute of Medicine, is a major contributor to this conversation of quality. This is the definition from the IOM. The degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Are consistent with current professional knowledge. Now remember, the Institute of Medicine, it's a think tank, brilliant people thinking about what quality should be. Each of us has an idea, however, of what quality means for us. In the same way as we have each of us has a unique definition of what health means to us, and it will change in time based upon what's happening in our lives, so have we that same about quality. How many of you, may I see a show of hands? It's going to be harder for those of you who are online, but if you want to raise your hand, go right ahead. Tell me, how many of you have known a family member or a friend who had alternatives available to them under the science, yet because they just did not want to do it, they decided to go home, right? Because that's our choice. We have free will. Even though the medical profession might be saying, we have current professional knowledge that suggests this, this, and that, if you will do this. It's still up to us, as long as we are emancipated adults, it's still up to us to say, I think that's right, or I think it's not. So quality, for all of us, there's still an individual definition of quality, and it's not always only about what the scientists have reported. They may be saying to you, in fact they will, we're giving you informed consent We're giving you as much information as we possibly can about the nature of the science. And this is what I would do, Alan. And Alan says, I think I have a different idea. I still can do that, have that right to do that. So quality means different things to different people. The Institute of Medicine, this is a popular operating definition for quality. What is the value of the services delivered as perceived by the patient? That's the underlying thought. What is the value as perceived by the patient? You might, if you're closer to my age, and there aren't many of you who are, I see, but if you're closer to my age, you might also suggest that 40 years ago, there weren't many people who said to the doctor, no, I won't do that. Whatever the doctor said is what you did, right? It was just kind of the way we did things in every community for the most part, or most communities, I should say. But I think that's changing. Access to information, changing behaviors of the millennials, the Z group out there. Younger folks think different from people who are in my age bracket. So we're changing. We're changing a lot. I see a lot of smiles. I'm looking through the camera. I'm seeing smiles out there too. Yeah. Access, the third cornerstone. Access, the ability of consumers, patients, to obtain health care when it is needed. Oftentimes we think of access geographically. Okay, it's within 20 minutes, I can go get it. Okay, it's down the street, I have access to it. Okay, it's in my town, I have transportation, I can go there if and when I need it. There are so many other factors that impact access. Let's explore only a few. The right to seek and receive it. There are some parts of the world, especially third world countries, where people in certain groups do not have the same right. They do not have the same legal right to access as others in that geography do. So, right to seek and receive care, that has a number of connotations. If I were to ask you generally, do you feel that health care is a right? Follow me here. A right or a privilege? Now, I would think most people who are working, spending their careers in Aphenia healthcare would suggest that, yeah, it's a right. Most of us would. And there are just a number of people who pay taxes and live in the country and reside here for whatever reason. They might suggest, yeah, I'm going to call it a privilege. And I'm going to say, I want health care to be available in some sort of basic form for people when in an emergency circumstance or other circumstances besides emergency. But for the most part, I think it's a privilege. In other words, I think the market should dictate. And if we have the ability to purchase it, then we should. Or we should have some sort of a Puritan ethic that gets us to working hard enough to obtain it. So when we explore this, the broader question is health care a right? Or is health care a privilege? Now, our country is a capitalist country. We are built on keeping the government out of it, not letting the government control it. And this is where the dynamic is. This is where the real rubber meets the road in this conversation. Is it a right or is it a privilege? Geographic availability, diffusion of technology, the third on your list of bullet points here. Diffusion of technology means what type of technology and where is it? The government does have a role in that. So for example, you're not going to have $3 million x-ray machines in every town of 10,000. Laboratory is dispersed in certain ways based upon cost and other factors. Information technology, which is growing and changing so rapidly, it's diffused in a way to get in the hands of people where they are more densely populated and in ways that help to cover the cost. Another type of technology is pharma, prescriptions, medications. It's a large component of the technological discussion. We don't always include pharmaceuticals as a technology, but that is what it is. So information systems and computer technologies, hardware and software, and then we have lab and x-ray and healthcare and other types of tools that we've developed to help us diagnose and treat, help us to improve. And then there's also pharma. 1965, I was alive then. I wasn't old enough to understand all these topics, but I was alive then. There was one insurance company in the United States, Blue Cross and Blue Shield. Blue Cross for the hospital, Blue Shield for the doctor. Now there are something like 1,500 different products of all different types. When I was born, something called a sulfa drug is what, and penicillin is what you were given. You know, whether you had a flu or you broke your leg or you had a car accident, you got penicillin. I'm being facetious, but you know what I'm talking about. That's what there was to prescribe. Today, it's beyond the comprehension of any one individual to know everything that's available, everything the FDA has approved for distribution of this technology. So it's very complex and costly. Personal financial ability is another component of access. What can you afford? So in the United States, if you don't mind, I will say we have the haves and we have the have-nots. The haves and the have-nots. Now, I should be fair here to also say, in those countries where there is universal access to care and an explicit global budget, there are problems there too. There are problems inherent with every system. You know, if you need your hip replaced and you're in a lot of pain, you might have to wait in some countries until it's your turn for that hip replacement based upon the aspects of the global budget. So that's just one generalized example of how an explicit budget may not work in our best interest if we think we want it done now. People in the United States are kind of that way. I want a cheeseburger, I'll drive through Wendy's, right? I feel that way. So our personal financial ability, our insurability, based upon income and often employment and other factors. Can we have access to insurance to protect us against catastrophic risk? Insurance to protect our financial out-of-pocket exposure in the same way that others have. Not everybody has the same insurability in the United States. It is not universal. And then finally, equity. Most of these topics lead to the question of equity. In other words, if you're walking, breathing, living, is it the same for everyone? And I think in the healthcare environment in the United States, we could point to ways in which there are the haves and the have-nots. It's based upon our system, a fragmented system. Comments, thoughts, questions about that? I'm doing a lot of talking and there hasn't been much response. Hello out there? Okay, don't want to become too theoretical, I promise you. But I want to go back to, on this hand we have what's a right, and on this hand we have what is a privilege. Which is it? What would you vote for? What have you voted for in the past? In the United States, what is it? So there are two broad theories or conceptions of the equal or the distribution of healthcare. One is called market and the other is called social. You can just underline them that way. The next 3 or 4 slides will cover these topics, and I hope it expands your thinking. Even if there are no questions or comments, I hope it expands your thinking, because this helps to illuminate what we face in the United States healthcare delivery system. Market justice theory suggests that the distribution of healthcare occurs through the market forces of a free economy, which makes it available based upon the willingness and ability to acquire it. So then, it's like a commodity like other goods. Your car, your home, a vacation, toys. Whatever you decide, it's within your wherewithal to invest your resources in. Under market justice theory, healthcare is like that. So I'll give you some examples of other ways that healthcare can be reviewed or viewed. Let's think about public education and our access to highway systems. Those are two good examples. All of us in the United States have access to a public education model. And for the most part, it's free to the consumer, except for certain local taxes we pay. Highway system, except in those places where they stop you on a toll road. Yeah, right? Go down through Oklahoma, you're going to run into that. Other places in the United States. But you pull out on I-70, nobody says, where's your $10? We get on it, we go. Because through the way in which resources have been allocated, certain systems in life have been put in place for us that benefit everyone the same way. The arguers, the defenders of social justice theory would suggest healthcare should be in that same way, but not the market justice theory proponents. They say, whoever they are, it's a commodity. You can choose to buy it or not. Individuals are personally responsible is another tenet of market justice theory. In other words, you're responsible for your own, just as you were before there was an insurance system, just as you were back in the Industrial Revolution. We live or die based upon what we do for ourselves. That, by the way, is in the American DNA. Very much so. People make rational purchase decisions. We assume, based upon market justice theory, that each of us knows what we're buying. We know what it costs. We know how much we're paying for it. And we're making a rational decision to acquire it. And finally, the distribution occurs best if there's minimal interference from the government. Minimal interference. Limitations of this market justice idea. Think about this now, because you can relate this directly to politics in the United States and health policy in the U.S. There's a direct link in our thinking. Market justice principles can fail to rectify critical human concerns that affect everybody. That's because of this idea of haves and have-nots. Market justice does not always protect society from harm, things that happen, plagues, communicable diseases. There are many other examples, but the market justice theory doesn't apply to all similarly or the same, so therefore it doesn't protect us. And market justice can work less effectively when consumers, that's us, have incomplete access to information. Economists call this an imperfect market. So I would suggest to anyone, including the most notable economists in the United States, try to figure out what it cost you when you went for a 3-day hospital stay. It's a virtual impossibility. You have to be willing to be a forensic accountant and spend 3 months there to figure out what it actually costs, because we have a different system for it. It's not like going to Walmart. If you go to Walmart this evening and you have a $79 bill, you can see what you bought. Now, you know what the price of that product was. You may not know what it cost Walmart to provide it to you, so you don't know the margin, but you know what you're paying for what you just got. A little different in healthcare. It's a whole lot different in healthcare. It's a lot more complex. A lot more complex. Next, social justice theory suggests that we distribute health care, and it's a civil responsibility, the benefits for which are based on need. So it's a civil responsibility. It's a corporate responsibility of the citizenry based upon need. Dr. Knitt.
It's actually going to go back to the market justice theory. So one of the problems too is that we don't often know a cost even before the procedure. People can't always even tell us. So like when you go in the hospital, you don't know that it's going to cost, quote, $10 for a toothbrush. Or do you have the option of bringing your own?
Right.
And so there is a lot of information lacking to be able to effectively make a decision. Do I want that or don't I want that? If you're in the moment and your nose is running or you're bleeding and you need a tissue, you just want a tissue.
Yes.
You're not making
right.
It's
not a $5. It doesn't have to be a $5 tissue.
Right. Right. I'll just take a little bit of that toilet paper in there that you're not going to charge me extra. Right.
You're going to take the toilet paper that they're not going to charge you for, okay?
That's right. Anyway, but so it implies that market justice theory implies that you have all of the information available, and you very frequently do not.
It's an imperfect market. I can really bore us to tears on a conversation about the imperfection of the market, how economists look at it, but it's because we do not have complete information. There's so little of the information we truly know we have access to. It's nested somewhere else. Right. Couldn't agree with you more. Now, that confusion exists in other societies and other countries, by the way, but the manner in which it is provided and paid for is different in many other countries than it is in the United States. Whether that's right, wrong, or indifferent, that's the fact. We're talking about health and society today. The first foray is to kind of understand what we do in the U.S. and how that is unique on the world stage. Too far. Tenets of social justice theory. Healthcare is different from other goods. In this way, we might argue that healthcare is sort of like the highway system, or access to public education for our children. In some countries, a college education is free to the citizen. There are many ways in which different countries look at different ways of providing services as a result of civil responsibility. So under social justice, the suggestion is it is a civil responsibility because healthcare is different. Is it? Is it not? Well, there's a considerable disagreement about that across the world, and especially in the United States. The responsibility is shared within society, so it's not only the person's individual responsibility, while that's important, and it's a shared accountability across all. There is an obligation to the collective good. That relates to number 2 very directly. And fourth, the government is better able to decide how much to produce and what, where, how to distribute care and services. This is problematic in the United States because a great number of people, even those who would vote for universal access to care, would also argue that we're not sure the government's the best place to operate it. So there are research studies that say just that, and the data is pretty compelling. Something like 58% of respondents to credible surveys have said we'd like to have universal access, but I'm concerned about the government overseeing it. That's what we have in the U.S. when we think about what needs to be done, right? It's not always the D's and the R's, the Democrats and the Republicans. We tend to have people put in those boxes, but we could go today to the offices of some Democrats who don't believe we should have access to universal access to care, and we could go to the office of some Republicans who would say, I would vote for that in a heartbeat. So it's not just Democrat and Republican, but it is how people generally think politically and ideologically? And these are difficult questions in the United States of America. Very difficult. Otherwise, we'd already have universal access to care. Several presidents have tried. And I could take us back to about 1932 when these conversations began in earnest. We could talk about what happened in Germany in 1880 that brought a social mindset to healthcare. That's where our social security system was born, by the way, in Germany in about 1880. Interesting, right? And you're saying, well, Alan, I'm surprised you knew that. You get my age and you read some stuff, you're kind of surprised what you remember. Limitations of social justice. So don't jump on immediately. I know that most of you have already agreed, I can see by your body language and hands raised, that I would vote for health care as a right versus a privilege. There are some disadvantages. Let's look at them. Cost a lot of money. It costs a lot to sustain social justice theory if everybody gets exactly the same amount. Sir. Explicit rationing and global budgeting place constraints on the amount of service that can be provided and thus may impact quality of care. That goes back to that illustration I gave you, or example of the person who has to wait 6 months to have a hip replacement living in Canada. And that is true. That is exactly what will occur sometimes. So you have to wait. Will that affect that person's quality of care? Well, maybe it would. Maybe it wouldn't. But in the United States, if you're insurable, if your insurance will agree with you, if you have the wherewithal, in other words, you can get what you need pretty quickly in relative terms to other countries. Yes, Fernita.
That's what I was, I know you see my mind just pondering.
I've seen your mind pondering. I'm sorry the rest of you can't, but I see your mind pondering.
It's a little confusing on how, I think some of the ways of the other countries and how we work are kind of the same when it comes to depending on what insurance you may have.
Okay.
You know, for, like you said, if you have the private insurance and you need a hip replacement, or you need something, it's accessible within the next week, they can get you scheduled.
Yeah.
But however, if you're, covered under Medicaid and Medicare, then you have to go through authorizations, and it still takes it could be 2 months,
right,
or 3 months, because it's controlled by the government.
Yes.
So they're still dictating. So it's
right.
almost like the other countries, but not exactly.
So accessing healthcare then through some means, say Medicaid or Medicare in some ways, might still mean you have a delay, right?
Right.
Because of pre-authorization, and that's all very true. Because Medicare and Medicaid and some of these other systems, the Indian Health Service, CHIP, what was S-CHIP? These are ways in which Congress has helped to assure benefits to certain groups within the U.S. population based upon criteria, factors. Not everybody,
Right.
but some.
And then even with another example using Medicaid is how they took away, years back they took away the access for dental
Yes.
for the adults.
Yes.
And what ended up happening is all the adults kept running to the emergency room being in pain.
Right.
It affected their other health issues, so then they added it back to
Yes.
give them that coverage to help them better quality of care. So they lost more and not covering them.
Right.
And kinda
So
like-
rather than a system of prevention,
Right,
right, it's a system of sick care.
right.
And there are many examples based upon lots of different factors where you could put 10 people in the room and assess their insurance status and their insurability, and you're going to find 10 different cases. All of you see this all the time, 10 different cases, and they're all different. You be a 45-year-old female, and all other things being equal, and have 10 different ways in which health care is accessed and paid for. And the outcomes might vary. The dental example you give is a great one because everybody has dental pain. And it hurts like the dickens when you have it, and you're going to end up in the emergency department if you don't have access to a different way, right? It's not just oral health care, it's a lot of different. You're sitting by a behavioral health expert. She would probably suggest, where's ours, right? So different ways in which we value services and service delivery based upon who we elect and policies. When it comes to how taxes are allocated, it's who we elect. Whether that, again, that's good, not so good, or we're indifferent about it. Public officials, elected officials make those decisions. Finally, the last on this list of limitations, healthcare disparities will remain. Because everywhere in the world, there are people who are more affluent than others. I remember an example when I was in graduate school, given by a professor. This person from a Mideast country, a very, very wealthy individual. I'm thinking it might have been Saudi Arabia. It's a country similar to Saudi Arabia, if it wasn't. This person needed some healthcare delivery and scoped it out, best able to find what he needed in Miami, Florida. Brought an entourage with him to Miami, Florida, rented the floor of the hospital, got the care he needed, was discharged, and wrote a check for it. So to suggest that there aren't some people whose affluence give them an ability to find their way through the system is a fool's errand, because there are those situations. People across the Canadian border in the United States get access to pharmaceutical products. The pharma industry is very robust in the United States, and they can't get it in Canada. Well, they're only crossing the border because they can afford to buy it in the United States, but they do. Again, that's just one example of ways in which affluent members of society have means available for making purchases beyond the benefit that is provided. I don't know how we get around that. There would have to be some sort of universal law that says, you know, if you do that, here's the harm that comes to you. It's such an egregious act, and I hardly think that's going to occur. That's just my opinion. So there will always be the affluent who have means that permit them to get things faster, maybe better than others. It seems to be just life. So I wanted to cover society, health and society, and give you some definitions as we find them in the literature, and discuss the determinants of health, and really how they relate, what they kind of mean, what we can control, what we can't. The cornerstones of health care: cost, quality, and access. And then, well, is health care a right, or is health care a privilege? Any questions or comments? Yes, Rebecca.
So earlier you mentioned that public health care started in the U.S. in the early 1900s.
Yes.
I'm wondering if you can expound a little bit on the history of healthcare that eventually turned it into the industry it is today. Because when healthcare first started, the doctors in the country were kind of spread out, and so it was not an industry, it was a mission or a service, but it wasn't, they weren't doing it to collect a paycheck or make a profit.
Right. Actually, that's where the barber pole came from. People would suggest that they had the ability to do certain things to help you with your health care, so they wrapped their barber pole with their red stripe. And that would inform your local community that this person had some sort of a concoction to give you to help you with your headache, you know. Again, I'm being facetious. I will do just that, Rebecca. The delivery of health services in the United States is next time. There's a pre-industrial phase, there's a post-industrial phase, and then there's a corporate phase, as we understand it in today's chronology. Pre-industrial relates to those times when healthcare was not systemized. Post-industrial relates to times when we started to have a greater level of urbanization. People were living in more densely populated areas. Medical schools became, got better at what they were doing after the Flexner Report in 1910. It was just prior to 1910, after some communicable disease outbreak, that we started thinking about investing tax resources in public health in the United States. So it's probably, the answer to your question is probably, it is more involved than the time we have remaining today will offer. But Series 4 is exactly about that history, and I find it to be fascinating. If there's a specific question you have, though, I'll be happy to try to address it. I don't mean to set it aside. We're going to talk about the history next time. Yeah? 1960, computers, corporate medicine, multinational firms. Just an amazing transformation. More happens in a day today than happened in 1,000 years ago.
The other question I had was, early on you said in the US we spend approximately 90% of total expenditures on medical care, and then when you were talking about the cost slide, you mentioned 17% is spent on healthcare. Can you?
Yeah.
I'm a little confused about the definition of
Thank you.
expenditures.
So our gross domestic product is what I'm referring to when I should be more clear. When I say 17.6% of our gross domestic product in the United States is spent on healthcare. So 17.6% of the 100% is on healthcare. Then we buy other services. Education, for example, transportation, all of these different ways in which we spend $1 bill in the United States, 17.6% of it is for healthcare. Of that 17.6%, let's say that that's $1,000, just for exemplary purposes. 900 of it we spend on the provision of medical care, 90%. Yet, of that 90%, that 90% only brings us 10% the value of our health determinants. So we're only impacted positively 10% of the total determinants based upon where we invest our resources. So $9 out of every 10 is spent on the provision of medical care in the United States, but that only brings 10% of the total determinants of health. Was that better? Still a little confusing?
A little bit. But
so we buy other things. We buy other things besides healthcare in the United States. Of the total amount that's spent in the United States in a year, 17.6% of it is on healthcare.
that part I understood.
Okay.
But you're saying 90% of the expenditures go to the provision of medical care. So does that mean like the red tape that's involved in providing the service we provide versus the cost of the actual service that's provided?
So it's all of that. It's the construction of a hospital. It's the provision of services at Affinia Healthcare. It's home health agency, paramedic services. You aggregate all of these. Of the total amount spent in the United States, 90% of that total goes to medical care, and which is disproportionate based upon how medical care actually affects and is a determinant of health. It's disproportionate. Yes?
I think the piece that might be confusing is that other 10% that he's talking about is going towards lifestyle behaviors, hereditary, environmental kinds of modifications that we might be trying to make. So the 17 point whatever, is all of these issues combined.
That's a great explanation. Thank you, Dr. Knapp. That's better than I did. That's why you said my All right, thank you for the question. Thank you, all of you, for your question. Anything else today? All right, we'll see you next time. Thank you.
Thank you.